Hi, everyone. Thank you for joining our webinar, the SUDEP Biomarker Challenge, What Did We Learn?, hosted by the Partners Against Mortality and Epilepsy, or PAME. I'm Dr. Kathleen Farrell, Vice President for Public Health and Outcomes at the Epilepsy Foundation, and I'm joined today by the Epilepsy Foundation's Chief Outcomes Officer, Dr. Brandy Fureman, and pediatric epileptologist and Adjunct Professor of Pediatrics at the University of Calgary, Dr. Jeff Buchhalter. Between 2015 and 2020, the Epilepsy Foundation hosted a $1 million SUDEP Biomarker Challenge that asked researchers and innovators to find predictive biomarkers with which to identify people at risk for SUDEP, or sudden unexpected death in epilepsy, or life-threatening seizures which compromise cardiac or respiratory function. Today, we'll learn about the proposed areas of work, discuss what was learned from the challenge, and the future planned steps. Your questions today are very welcome and very encouraged. Please submit those via the Q&A or chat box function in this Zoom. With that, Dr. Fureman, you're welcome to begin.
Thank you, Kathleen. It's great to be here and to share with you the outcomes of this really innovative approach to generating new advances in the area of SUDEP prediction and prevention. I wanted to start out by just reminding us all of the context in which this challenge was offered. Many of you have seen a slide like this in the past that shows that previous to the early 2000s, research efforts in the area of SUDEP were really under investigated. There were very few publications that mentioned either SUDEP or unexplained death in epilepsy. And it really was due to the incredible efforts of individual families who had lost those loved ones to SUDEP, and organizations like Cure Epilepsy and the Danny Did Foundation and many individual family foundations who stepped up and said, we need to start paying more attention to this issue and talking about it, both with clinicians and with our research funding agencies. And with that, there was a dramatic increase in the amount of work that went into the SUDEP field, accelerated, I think, quite a great deal by the efforts that the National Institute of Neurological Disorders and Stroke put into a Center Without Walls for SUDEP research. So you can see that after a slower start in the early 2000s, we really got into this very dramatic increase in the amount of investigative work happening in SUDEP. And it was right around the time of 2013, 2014, that the leaders of the SUDEP Institute at that time, and those were folks at the Epilepsy Foundation, including Cindy Wright, who is now a colleague at CNF, and then later directors of the SUDEP Institute like Sally Schaefer, and folks even today who work on our SUDEP program, Alison Kukla, Kate Brocker, and Caitlin Greskoviak, have all helped to participate in really taking this challenge and moving it forward. And they were assisted by a tremendous number of advisors and caring, compassionate, and bereaved donors, and other people living with epilepsy who really care about this issue and want to see things change. So I want to just point out to you that, in the area of about 2015, we had seen this big increase in the number of at least research publications describing SUDEP, but we still didn't have a strong understanding of risk factors that would be modifiable or predictive biomarkers that would help us understand who was at highest risk. Really at the time, it was the folks who were experiencing generalized tonic-clonic seizures, the most frequent of those seizures, and those who had the earliest onset of those seizures. And so the SUDEP Institute took on a novel approach to trying to generate new ideas in this field to try to get to the place where we could say we had a validated biomarker or biomarker panel that would help us identify those people at highest risk. And the obvious hope there was to generate better trial designs for prevention studies, to find those risk factors that could be modifiable, and to really start to make a dent in preventing SUDEP from happening. So the innovative novel platform that was developed was something called the Innocentive platform. And this is it still exists today, a challenge-based platform where sponsors can go put a challenge out to the community. And this is a worldwide community. And it's not restricted to, biomedical researchers by any means. There are folks from all sorts of different walks of life who come to the Innocentive platform and look for challenges that they can offer solutions to. And so at the time, the SUDEP Institute brought together a group of partners who were interested in offering a challenge around SUDEP and SUDEP prevention. And it really was a combination. This $1 million prize was offered for a combination of different solutions. So the very first challenge that was offered was one around education and empowering people with more knowledge about SUDEP and the ways to try to reduce their risk for SUDEP. The winning solution from that challenge became the Aim for Zero campaign that hopefully some of you remember, that focused on behaviors that you can adopt to try as much as possible to reduce your risk for SUDEP, knowing it's not always possible for everyone to reach zero seizures, but the rationale behind that solution was really trying to address the known factors at that time. In challenge number 2, the goal was to help prevent seizures in people who had epilepsy already. And the winning solution there was called the EPSMON mobile application. And that was more of a self-monitoring app-based product that was delivered by a team from the UK. In challenge 3 is when we started to get into this idea of biomarkers and identifying potential biomarkers for SUDEP and SUDEP risk. Challenge 3 was really a theoretical kind of challenge. And what that meant was it was open to anyone who could propose a theoretical approach for identifying a biomarker that could serve as a marker of risk for SUDEP and seizures. So we got a number of very interesting applications for this solution. You can imagine that by putting a solution marked $1 million challenge out there to the world, you could get a large number of very interesting kinds of ideas. We did. Some of them were fairly nonsensical and didn't make it through to the review phase, but we were able to identify a number of winners for that challenge, some of whom then went on to proceed to the actual more concrete steps of challenge 4. And what was required in challenge 4, and this was where the large prize money was aggregated, was for a series of steps in which people developed a detailed project plan for how they would show the validation of a particular biomarker. Milestone 2, which was a separate application process and a separate review, to show that they had proof of concept data for the biomarker that they were proposing. And then milestone 3, which was the final milestone of this major challenge call, was to show that they had validation of a predictive biomarker that had adequate sensitivity and specificity for predicting SUDEP or near SUDEP seizures and risk. Okay, so I wanted to say a little bit about the criteria that were included in that last milestone. The review required that the applicant show evidence of clinically relevant, specific, and sensitive biomarkers of SUDEP and near SUDEP, ideally that would help to facilitate the development of interventions. The challenge was open to biomarkers from many different types. And so, we listed different examples of types of biomarkers that people could think about, but it was not limited in any way. And then finally, there was a criteria that the biomarker or panel could be easily and safely measured, cost efficient to detect, modifiable with intervention, and consistently associated with SUDEP or near SUDEP. Again, that relates back to its sensitivity and specificity, and that would drive, the biomarker would be able to drive interventions into SUDEP. So that was some of the fairly strict criteria that were required during that challenge. And I should remind you, as Kathleen said in the introduction, this entire process happened between 2015 and 2020. So all 3 of these large challenges, the education, the educational self-monitoring intervention, and the biomarker, happened within that time frame. Okay, so we tried to use a rigorous approach to evaluating the applications that we received. And this is the steps that we followed. So in the initial screen of all the submitted solutions, both staff at the Innocentive platform and our Epilepsy Foundation research staff looked through each and every one of the applications just to make sure that they were meaningful enough to send forward to review. As you might imagine, we did get people who simply pasted together a number of publications and sent that in as their solution. That's not what we were looking for in this final challenge. So those types of applications were screened out. Innocentive also does a screening process for individual solvers. And that is, number one, to make sure that the solver has the rights, the intellectual property rights to deliver the solution, more of a legal and administrative review. And then finally, the peer review that was held was convened by the Epilepsy Foundation. And we developed a sort of a three-staged review process. First, we had a team of academic reviewers that included epilepsy clinician scientists, both adult and pediatric epilepsy clinicians and basic researchers who went through the applications for their scientific technical merit. We also had a statistician review each and every one of the final applications, really trying to get at that question of, have they shown that the proposed biomarker has been validated, clinically validated, meaning that it has adequate sensitivity and specificity in a large enough population that we could rely on this as a validated biomarker. And we were lucky enough to have a statistician who had special expertise in biomarker evaluation help us with that piece. And then finally, we had a panel of family members and people with epilepsy who also looked through the applications, and their perspective was really focused on the acceptability of the biomarker, the feasibility for families and for people with epilepsy, and their experience of SUDEP and seizures in the context of how this biomarker might work in the real world. So we had wonderful feedback from each and every one of these groups. And that feedback was shared to the team at the Epilepsy Foundation. They came together with a set of recommendations. And Jeff will be able to tell you about each of the finalists and what we ultimately decided for this panel. And I wanted to offer a resource here. If you'd like to read more about any of the winners of the previous challenges, we have a good deal of information about each of them on this page on the epilepsy.com website. So I think at this point, I'll turn it over to Jeff, who was one of our august reviewers. Jeff, thank you, and everyone who participated in that review process. It was incredibly helpful.
Thanks, Brandy, and thanks everybody for joining us today. What I'd like to do relatively briefly, so as to leave as much time as possible for questions, is just give you a snapshot of what the 4 finalists submitted. And as Brandy said, this was after a lot of review by as many people from as many communities as possible. So the first finalist was from a group at the MIT Media Lab. And this was pretty cool because this is a group of very high-end scientists who weren't in the SUDEP space, who came together to try and create a biomarker for SUDEP. The one they submitted was called AGAPA. And the reason I say AGAPA is because they gave us instructions. It's how it's pronounced. I still don't get it, but that's how they pronounced it. And so what this group wanted to do was to use machine learning, artificial intelligence, using a panel of features inputs to produce an output that classified whether a new person's seizure events were closer to those that have succumbed to SUDEP versus a group that had not. And so the variables that they used were, first, the A is history of apnea. The G is generalized tonic-clonic seizure. The A is accelerometer, movement. The P is the presence or absence of supervision while a seizure is happening. And the E is an electrodermal response, which is a measure of autonomic function. The reason I keep doing this is because the physiologic, as opposed to the historical variables, were measured from a watch. And the watch was the Embrace monitor that measures electrodermal response and movement. The rest of the features were historical inputs into the model. They, as what Brandy said, this had to be related directly to SUDEP. And so in this presentation, they had information from several individuals who had succumbed to SUDEP while wearing the Embrace monitor. That was a total of 4 individuals. The control individuals were derived from those which had those parameters recorded in 3 epilepsy monitoring units. So the point to make here is a very limited number of patients. And what they found that by using this model, combination of historical information and information from the patients who succumbed to SUDEP, they could classify who is more likely to have SUDEP from those that weren't. Certainly not 100%, but a statistically significant difference. So that was the AGAPA panel biomarker. The second entry was titled Phase Amplitude Coupling in the Scalp EEG as the SUDEP biomarker. This is from 2 established investigators in Canada, Dr. Bart Jayan and Dr. Peter Carlin. So this uses surface EEG, scalp EEG, that's readily available. And that's sort of part of the thinking of if you can't readily measure it, it's not going to be a useful biomarker. So in the case of the first set of investigators, they used information from a wristwatch and historical. This was information derived from scalp EEG. These investigators, just to know, use not only scalp EEG from people, but they also have rodents hooked up to EEG, and they do computer modeling. So trying to approach the problem from a variety of aspects. In the human studies, they had information from 8 SUDEP patients and 6 non-SUDEP patients. And so what they were able to demonstrate is this measurement of EEG, phase amplitude coupling, was fairly robust in separating the 2 groups of SUDEP and non-SUDEP. So that was their submission. The third one was called the EFA Bayesian final. This was a paper published in 2021 in Neurology. And again, a very different approach. What this group of investigators did is they looked at individuals from 4 published studies of SUDEP, 287 instances of SUDEP and 986 controls. So now we have much, much bigger numbers. They used 22 clinical predictor variables that were available in the literature, and they put these into a Bayesian logistic regression model. And what they found was that by combination of variables, there was a greater ability to predict who was going to die of SUDEP than from just looking at generalized tonic-clonic seizures alone. And the model was in the public domain. The final submission involved heart rate variability. And this was an international study with most of the investigators in Australia, involving folks we know very well in the SUDEP community: Warren Davinsky, Terry O'Brien, Sam Berkovic, among others. And what they did is they pooled their information that they had at their individual centers, and in the end had 31 instances of SUDEP and 56 living epilepsy controls. And again, it's always a challenge to say what is the right control group for comparison. They focused on heart rate variability, which is a very strong predictor of cardiac death. And what they found was that even though there weren't differences in the time domain of heart rate variability, there was differences detected with spectral analysis, which is frequency of the EEG. And the finding was that the low frequency power during wakefulness separated those which succumbed to SUDEP from those which were still living. And this low frequency power metric is a validated biomarker for sudden death in the cardiac population. So it was pretty encouraging. So those are the 4 finalists among many excellent submissions. Go to the next slide, please. So what were the conclusions? The first there wasn't a clear winner of the challenge, and I want to emphasize the as it was written, because the challenge was written to produce a robust biomarker that was validated, relatively easily applicable, and cost effective. So we set the bar pretty high, and no one met it. The observation from really the vast majority of the reviewers is that more data was needed and correlations for each solution to move forward as an excellent biomarker. And then what emerged was actually really nice, I thought. There was a great interest when everyone sort of got together in the room, the virtual room these days, that there was interest in the teams collaborating with each other, because it was clear that deficiencies in one, like the number of people involved, were met by another group. So this whole idea of collaboration between groups sort of bubbled up organically. And then the other final conclusion was that there was interest from others in seeking additional avenues for support, so each team could work themselves or with others to advance their solutions. And that's the summary of that. What did we learn? Well, I think we learned a great deal. First of all, we don't have a validated biomarker for SUDEP as yet. A real take-home message, I think, was that the 3-year time span was too short. This is a terrible question, and it was probably unrealistic to think we were going to solve it in 3 years. But gee, there were some great efforts. The next bullet, sort of reality from what you saw, is that if you're doing things retrospectively from individual units, it's very difficult for any one group of investigators to fully validate a biomarker in people. And that's sort of the good news, that SUDEP is relatively uncommon, but horrific when it happens. But the bad news is it's hard to demonstrate the validity of a marker when you have very few people. The bullet in green, I think, was a sort of a take home for me, is that there are multiple biomarker types. And I think when we started, we sort of had the idea that one would emerge as the answer. And I think we're thinking that's not true. It was very rewarding to use the Innocentive Challenge, because people that weren't involved in the SUDEP space were brought in. And clearly, if we had solved the problem with the available resources and people, we wouldn't have had the challenge. So this was a great way to get other folks involved. And the next step is obviously to get adequate resource support and access to a sufficient number of individuals affected and appropriate controls to move forward. So that's what we learned. Brandy, you want to take it from here?
Sure, and Kathleen, please chime in. But I wanted to let everyone know that in terms of next steps, the foundation did organize a virtual meeting, as Jeff said, of all of those finalists to discuss where are there opportunities to collaborate, to synergize together. And we did get good positive feedback that there may be some possibilities between at least some of those groups to work together. We believe that, given that we did receive some restricted funds and some agreements to fund if a winning solution was identified, probably the right next step is to work as a collaborative through PAME to try to figure out what is the right next step for moving this work forward. So very grateful that we've been in discussions with Gardner and the PAME advisory group to think about how that might look in the next phase. And I also wanted to especially thank the many advisors, the partner organizations, and individual donors who committed to helping to raise funds to get this challenge off the ground. I think it was absolutely worthwhile, and we did learn a good deal. The outcome is a mixed good and bad, but I think we definitely created some new pathways to travel down in this field. So thank you to everybody who was involved. Thank you to the applicants who put forward their ideas and spent time working on those new solutions. So Kathleen, I'll turn it back to you to close us up.
Thank you. I think now is a great time to transition to questions. We've gotten a lot through the chat and Q&A functions. One of the major themes I'm seeing in the chat box is the reluctance of people to discuss or broach the subject of SUDEP with people and families affected by epilepsy. Can you or Jeff speak a little bit to that and what we know as epilepsy or advocacy organizations?
Sure, and as many of you know, that's been a major area of interest and concern for me for some time. The why not discuss, and I think one has to. And I'll give a couple. I'll throw out a couple of answers, and please others respond as well. Part of it is history, and as Brandy showed in that introductory slide, the awareness of SUDEP didn't really hit the scene until about 1997. So if you use that as a sort of start, what that means is that prior to 1997, which is when many practicing neurologists were trained, death in epilepsy was considered to be due mainly to status epilepticus or aspiration pneumonia. And when people asked about, am I going to die? Our response was pretty much that. No, it's pretty unlikely you're going to die. So we're going to keep you out of status and aspiration. And that was the answer. Also, in terms of advocacy, there was a huge effort during those decades to make sure that people living with epilepsy lived as normal lives as possible. And a big part of that message was living well with epilepsy. So the emphasis was on the functional aspects rather than the very significant comorbidities, which we know exist, and especially death. So I think there's a huge historical component of why not talk about it? And I think the answer is in the minds of many of the older neurologists, of which I'm one, it wasn't part of our training or experience. So that's one part. Another part is sort of the maternalistic nature of medicine and neurology, of the provider thinking, we know what's best for you. And it's not done with malice. It's done with the best of intent of wanting to spare people from undue psychological harm, even when it is, number one, incorrect, because SUDEP is a real thing and there is a possibility of dying. And number two, I think ethically, it's our responsibility to discuss the worst possible outcomes of epilepsy with patients and families, just as they do in the world of cancer. But the providers and the community sort of had a different mindset. So history, paternalism, maternalism, and then the last, and probably part of the second, is the fear of doing harm, of upsetting, depressing people, freaking them out. And finally, the perception, again, incorrect, that there was nothing you could do about it. Whereas in fact, we know that from the risk factors associated with SUDEP, one can move towards prevention by seizure elimination with medication, surgery, devices, and diet, and likely supervision. So, in a nutshell, I think those are a number of reasons why it hasn't been discussed as it should be.
Thanks, Jeff.
Yeah, and Jeff, I'll add to that. We know that it's still going on, that folks are being treated for their epilepsy, but SUDEP is not mentioned. We recently had a large gathering called Epicon, and we had a number of sessions on SUDEP at Epicon. And I can tell you that I spoke personally with a mom and a son who, left that session floored, having never been told that this was a possibility and very nervous about what it meant for her son. But we were able to have that conversation. And I think when you can arm people with some education and knowledge, folks want to know this information, and we know that at this point. In fact, Jeff, you may want to mention there's now a guideline from our neurology professional associations that essentially requires this kind of conversation with folks. So that's a step in the right direction.
Yeah, Brandy's referring to the American Academy of Neurology 2017 guideline on SUDEP. That took 10 years to develop, I may add, because there was such concern in the neurologic community. But it's out there saying that SUDEP should be discussed with adults, patients, and families of children who have SUDEP, who have epilepsy. And as Brandy said, this is still an ongoing phenomenon. Every year at the Partners Against Mortality and Epilepsy meeting, which we started in 2012, we sit with families, individuals, and probably their number one statement and pain and complaint is that SUDEP was never discussed. And so it's something that is still a big, big issue.
So we've also just released with our partners a new sort of awareness campaign that talks about Start the SUDEP Convo. And that is something, if you see that on social media and you can help amplify that message, that's a way that you can help to try to get the message out there that this is something that we should be talking about, families are ready to talk about, and there are ways that we can approach, trying to reduce risk.
Thank you both. In that same vein, I'm seeing questions related to, the fact that coroners often are not recognizing SUDEP or listing SUDEP on death certificates. Can you talk a little bit about what we know there and, work that's being done to improve that state?
Yeah, that was a big aha moment, probably 5 to 7 years ago, when the SUDEP community realized that the number of instances of SUDEP was being underreported. And a big part of that reason is because the certificate of death, which is sort of the the gold standard from coroners and forensic pathologists, was not listing SUDEP as a cause of death. Subsequently, the work of people like Orrin Davinsky and Cindy Wright, Elizabeth Donner, and others got together with the National Association of Medical Examiners to have this discussion. And it was bringing an issue to them which was difficult, because in the way they were trained, SUDEP wasn't the thing. And through really a lot of very productive, collaborative discussions, National Association of Medical Examiners published a white paper just a few years ago saying that SUDEP should be considered as a proximal cause of mortality. So that was recognized, it was worked on, and it's getting better.
I can just add to that many of you in the field should be aware of a registry called the Sudden Death in the Young Registry, which is funded both by CDC and by NIH. And one of the mandates in that registry, and it works through the process of child death review in a number of states and regions throughout the country. That team actually goes through with a fine-tooth comb records that would help them determine whether an unexpected death in a young person may have been due to a cardiac event or a SUDEP or some other underlying cause. And so the fact that those sudden death in the young sites exist across the country really, I think, is an educational opportunity for us to make sure that the medical examiners, the coroners who feed into those sites understand what's coming back out of the registry. When they identify that a case is likely a SUDEP, that's a chance for us to go back to those individuals and say, these are the criteria that you should be thinking about when a case like this comes into you.
Thank you both. There are also questions coming in the area of genetic testing and examinations of, comparing people who have passed from SUDEP versus people still living with epilepsy. Can you talk a little bit about that and maybe the work that's being done to look at samples of people who have passed and donations from families?
Yeah, and that's been a hot topic for a number of years. A bunch of investigators have looked at this, and the folks that come to mind are Alicia Goldman and Jeff Nobles at Baylor in Texas. Alicia has a registry of samples if folks want to participate, and it's a complicated story. It sort of falls into two buckets. One bucket that they've really pioneered is the finding that there are certain channels that exist in the heart, some of which also exist in the brain, which can cause fatal cardiac arrhythmias. And certainly when those are discovered, that's a potential big risk factor for SUDEP. The other bucket, and I apologize to the real scientists who understand this much better than I, are genes which are associated with, but not necessarily causative of. So looking at the genetic background. And this is a huge issue, because as neurologists, we have individuals in our practices who have many seizures, tonic-clonic seizures, and they don't die. Versus the reality that there are some individuals that will have just a couple of seizures and then die of SUDEP. What's the difference between these two groups? And so those are the kinds of questions that the geneticists are trying to work out.
Thank you. There are also questions coming through about, role of devices in possible prevention of SUDEP or other means of prediction, like patient-reported outcomes that may be being captured between last seizure and an occurrence of SUDEP. Can you speak a little bit about that?
Yeah. Jeff, can I say something just first off? One of the limitations of the Innocentive Challenge, I think, is in the way that the challenge was structured around intellectual property rights. And so my conclusion is there may be other devices out there that could be promising that did not come in through this challenge structure simply because of that, intellectual property consideration. And so I just wanted to say that, Jeff, as a precursor to your comments, because I don't think that we really saw the full picture of what might be possible with different devices.
Yeah, no, that's a great point. So I guess the response is, first of all, it has never been demonstrated that any device has prevented SUDEP. And we have to be clear about that. The way that devices are approved by the FDA is their ability to detect seizures. It makes sense, and it's a logical leap, that if one has generalized tonic-clonic seizures, it would be smart and useful and hopefully preventative for someone in the area of the person having a seizure to be informed of it via some kind of device. So there is appropriate enthusiasm in the development of devices that record seizures. There's another line of investigation of using that information to predict seizures, which is a whole other thing, and then to be able to inform someone, like in the next room, that a seizure is occurring, and also send that kind of information to a care provider, if not in real time, but for seizure monitoring purposes. So I think there's a bunch of important applications of devices.
Thank you. There was a question in the Q&A that came out regarding a recent report of finding a biomarker for SIDS. Do you think that this provides additional hope in finding a biomarker or biomarkers for SUDEP? What do you think this says about the state of the science?
I'm optimistic, but that's my nature. The science that's coming through is truly astounding. We all are just appreciating it with regard to the revolution in genetics, and that has been followed now by the big things, obviously artificial intelligence and machine learning, some of which we've had an example of in the SUDEP space. So, I believe the science is moving forward with rocket speed, and a big part of it relates to funding. You can't do the science if you're not funded. And I think that's where this larger community comes in encouraging our legislators to get on board with the various initiatives in the NINDS, EF, the American Epilepsy Society, AAN, all the folks, CURE, that are pushing for more research dollars. This is my hope. And I think this is where the community plays a major role, because there's scientists out there that want to do this work, but it needs to be funded.
Yeah, I'm optimistic as well. And I wanted to just highlight that I think there's another lesson that we can learn from the SIDS community, which is, yes, while a biomarker is incredibly important and will help us hopefully get to zero SIDS deaths, there was a huge amount accomplished with an educational campaign that intervened on a known risk factor, and that was babies sleeping on their stomachs. So that back to sleep campaign, which rings in everybody's heads when you think about SIDS, also was incredibly important at reducing deaths. And I think we can learn a parallel lesson here. It's not perfect. It's not going to get us to 0 SUDEP deaths, but we may be able to make a big, big dent if we raise awareness about SUDEP, if we encourage people to take on those behaviors that they can, and again, it's not going to work for everyone, but where we can reduce or eliminate seizures by better medication adherence, by following good sleep hygiene and all of those, pieces that can be incorporated into managing your epilepsy, that too can make an incredible difference. And I would love to see us really take on that educational and awareness challenge while we are continuing to push the science towards the biomarker.
Thank you both. There was a couple of questions. I'm seeing a question about, we know of this concept of near SUDEP, where, people have been intervened on early enough to prevent the SUDEP from occurring. What interventions, if any, are known? There's a question about whether, shaking someone to rouse them from a seizure that could cause SUDEP, whether that's possible or appropriate. What can you share about this?
Yeah, so there is something called near SUDEP, and that is a term used to describe the situation where it looks like someone's going to die, cardiopulmonary arrest, and they are resuscitated. Currently, our thinking is you want to do sort of the standard CPR kinds of things, opening the airway, providing breaths, chest compressions. That's the near SUDEP, and so it's certainly that's sort of the follow-up to the device question. If someone has had a big seizure and one arrives to witness it and they stop breathing, what can you do to help them breathe again? That's what you do. And so that's why we encourage folks to be trained, families to be trained in CPR. One also has to say that you can do all those things and someone can still succumb after a seizure. And the reason I always mention that is that obviously there can be an enormous amount of guilt associated with either not knowing or being there and doing something and not being successful. And in the hospital, it has been recorded that there have been unsuccessful resuscitations associated with seizures.
Getting a lot of questions as well in the chat about different risk factors and mitigating factors. Few people mentioned various rare epilepsy syndromes and whether those are at increased risk of SUDEP versus someone without a rare epilepsy or a known genetic cause of their epilepsy. Can you talk a little bit about that?
Yeah, the syndromes obviously are all different, but many of them that are associated with motor seizures like tonic-clonic are associated with a much higher rate of SUDEP. And the ones that come to mind is Dravet syndrome, where there's been the greatest amount of data because there's been the largest number of people that have been reported. So yes, that is absolutely true.
There's also a question about whether there's any one predictive test to inform someone whether they're at risk. And, in absence of something like that, do you have any recommendations on how people can build that communication or conversation with their provider to evaluate their own risk?
I think it all starts with a conversation, and it's the conversation of partnership, I think, as to how as a team that involves patient, family, physician or nurse provider, genetic counselor, everyone that's involved in the team. How do we work on this together? Opening the conversation about risk of SUDEP, I think, is the first biggest step. And then it goes in many directions depending on the specific situation. It's very different for the child that's had one simple febrile seizure or childhood absence epilepsy. It's a totally different conversation from someone that has Dravet syndrome. Again, is a different conversation from a different seizure type and age. If there's a family history of heart problems, that could lead in the direction of more of a cardiac evaluation. So I think it just involves opening the discussion and saying, how can we optimize the likelihood of seizure freedom?
Yeah, and I'll add too, Jeff, on the Epilepsy Foundation's website, epilepsy.com, but also on many of our partners' websites. I know Danny did, and Cure Epilepsy have sections specifically on SUDEP and offer some tools that you can use to talk with your provider. So I would encourage anybody who would like to open that conversation to check those out. And maybe there's a way we can disseminate some of those links out to people who have attended the webinar, but encourage you to start the conversation. It will not be a comfortable one, but it's an important one. And you have resources and folks here to support you.
Absolutely. And I'm seeing, messages from people like Gabrielle, Stephen, and Renee in the chat who have all lost their loved one to SUDEP, and your involvement in these conversations and your insights and what you've learned. We want to definitely thank you for that, and of course are heartbroken for your loss. But thank you for communicating your insights here, and we hope to improve for other families in the future. And Tanisha.
I just want to echo Kathleen's words in expressing our heartfelt sympathies for what's happened in your families and your lives. Our thanks for participating in this webinar and for the Partners Against Mortality and Epilepsy and all the things that we do nationally and the things that you do in your communities. Because that's where it's all happening, and it's hard not to talk about SUDEP and not just be depressed. But I want you to know that there's a recent publication from the North American SUDEP Registry, led by Dan Friedman at NYU, and what they show in two jurisdictions, there's actually been a decline in SUDEP rates over the last few years, which is the first thing like it that I've come across, and it's encouraging. I want to believe, without any data, that it's the result of the kinds of things that Brandy is talking about, of public education, meaning providers and patients and families about the whole SUDEP issue and things that are being done on an individual basis to try and prevent it. So just to know that what the data shows is that there have been some declines. So whatever is happening, it seems to be in the right direction.
Thank you both. Seeing another few comments in the chat that really, I think, are standing out, just to say what we've heard from Jeff and from Brandy is that communication with providers, sharing what you see, what your worries or concerns, and asking the right questions that are on your mind is critical. And we do encourage you to have those personalized conversations with your providers. We can't provide medical advice on this webinar. So that's what I would just emphasize is please do communicate these and don't hold back your questions in that relationship with your loved one's providers. And seeing comments about education and the importance. And again, thank you very much, everyone, for sharing your insights here. And I'm going to be mentioning a few resources. And of course, there's many organizations that are providing information, support, resources, and more information about SUDEP and how we can work towards reducing loss from this awful occurrence. Thank you at this time to our presenters and to all participants for your interest and engagement today. It's been a great session on a really difficult topic, but we will be making this recording, and I believe the slides available in the next day or so. You'll receive an email once the recording is up on PAME's website. I do want to share a couple of opportunities to consider before we wrap up. The Epilepsy Foundation offers bereavement support to families and individuals affected by loss of loved ones from SUDEP and other epilepsy mortalities. This support, alongside other resources to learn more about SUDEP, its risk factors, and how to prevent it, are available on epilepsy.com/SUDEP. You can also send any questions to an inbox, sudep@efa.org, and that does have a dedicated EF staff person to reach back out with you and connect you with other resources. We'd also like to share information on a save the date for the 2022 PAME conference. It is a family and scientific conference that will be held November 30th through December 1st in Nashville, Tennessee. And this will be in line with the American Epilepsy Society, or AES, meeting. Thank you again to everyone who's joining us today, whether you are a person with epilepsy, have a loved one with epilepsy, or have lost a loved one to SUDEP. Also to our partners and other member organizations of PAME. We are, dedicated to being in this together. And thank you again for your interest in this topic. Take care, everyone.